Next one I'll talk about is the nasal airway, or so you will hear me refer to these as NPAs, and I didn't tell you the other ones. The oropharyngeal is an OPA. So that's what we just talked about. This is the NPA, the Nasopharyngeal Airway, or the nasal airway. And this is used on responsive patients, or any patient who needs some airway support, needs an airway adjunct, but has a gag reflex. So this is responsive patients who need help keeping the tongue out of their airway. Insertion does tend to be uncomfortable for responsive patients. And if you can imagine, well, we'll talk about how you put it in. So first thing you're going to do is measure from the tip of the nose. So you can see the flange there is lined up from the tip of the nose down to the earlobe. Ensure that the airway, so basically you're provided with a couple different sizes. And it's not just length, it's also basically what's the diameter of the circle. Hopefully not one ever that big. I think that's a giant nostril. But basically, what is the diameter of the circle, of the little tube that you're going to put in? And you have to look and make sure that it'll actually fit through the patient's nostril. You want to lubricate it with a water-soluble lubricant. And you're going to insert this with the bevel. It's hard to see on here, but it is actually beveled toward the base of the nostril or toward the septum. The reason that we do this is because the septum contains what are called turbinates. And they're very vascular. They have a lot of blood vessels in them. So if you start jamming things up your nose, it tends to make these turbinates bleed. So we use it with the bevel toward the septum so that it basically keeps us from bumping as much into those turbinates. All right, so we've inserted the bevel toward the base of the nostril or septum. Hopefully we don't meet any resistance, but if we do, then you're going to try the other nostril. In patients who have mid-face trauma, so maybe they took a baseball bat to the face, or possible basilar skull fractures, don't worry, we'll learn about this. That's an arrow. We will learn. So yeah, don't use them in those patients. The problem with that is basically there's a bone kind of here-ish. There's kind of a wall that separates your face from your brain. But if you fracture your face, you can fracture this bone, and basically if you take and put this NPA in, it can go straight through and into the brain. And that's not really very good. That's poor form. So when do we use nasal airways? Well, anytime you have a patient who is unresponsive but has a gag reflex and needs an airway adjunct. So a good indicator would be that a patient is snoring, and you'd maybe try an OPA and they have a gag reflex. I will say that sometimes these patients are mildly responsive to pain. They'll maybe kind of open their eyes and look at you and then go back to snoring. And if that's the case, it may be that you try to put an NPA in these patients. But basically, anytime you hear what we call adventitious, bad. So basically sounds you're not supposed to hear. Adventitious sounds like snoring in the airway, then you're going to want to put some sort of airway in. If they have a gag reflex, they get a nasal airway. No gag reflex, they get an oral airway. There are some limitations with this. Nasal and oral airways are not what we call definitive devices. So a definitive device is basically one that gives medical providers complete control over the airway. They are ones that basically go into the trachea, and there's a little balloon that inflates. They're called ET tubes, endotracheal tubes. And the reason that they're definitive is because they seal off the lungs from everything else. The reason that this is a big deal has to do primarily with the fact that people can throw up if they're unconscious. They can still vomit. The problem is they don't get it out of their mouth. So it kind of just comes up the esophagus and it sits there in the back of their throat. And it can actually go into their airway and it can cause massive infections. So it's called aspiration. And nasal and oral airways do not prevent aspiration. And that's the big key with this. They don't prevent aspiration of stomach contents, of anything, into the lungs. So manual maneuvers must be used with nasal and oral airways to ensure that the airway stays open. So it may be sometimes that you can put an oral airway in and you do an okay job keeping the airway open, but not always. So you're probably going to need to use manual maneuvers to really help it out. Patients may still require frequent suctioning to remove blood, vomit, and other secretions from the airway. So suctioning is not a one-time thing. Definitive devices such as endotracheal tubes, like I mentioned, are required to completely protect the airway. We don't put those in. EMTs do not put those in. This is something that ALS or a doctor can do. MD, medical doctor. So ALS or a medical doctor can do that.